Can Rituximab improve outcomes for patients with relapsing nephrotic syndrome? How can firearm violence be reduced by 2040? Should SGLT2 inhibitors be used more in patients with chronic kidney disease? This and much more on today's JAMA Editor Summary. Hello and welcome to our listeners around the world. Today is Friday, November 7th, 2025. I'm Dr. Linda Brubaker, a JAMA Deputy Editor and the Editor-in-Chief of JAMA Plus Women's Health. Today I'm sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by co-host, JAMA Deputy Editor Dr. Preeti Malani. Hey Preeti, let's get started.
Hi, Linda. It's Kidney Week 2025, and JAMA has a great collection of content for readers and listeners. Let's jump into our discussion with the trial evaluating Rituximab for nephrotic syndrome. Nephrotic syndrome, like minimal change nephrotic syndrome, is characterized by severe proteinuria and hypoalbuminemia and can usually be treated with corticosteroids. However, some patients experience relapse during corticosteroid tapering. Rituximab, an anti-CD20 monoclonal antibody, has been associated with remission rates of 65 to 100% for frequently relapsing nephrotic syndrome or steroid-dependent nephrotic syndrome in observational studies, but Rituximab has not been approved by the FDA for adult patients with these conditions. Dr. Asaka and colleagues conducted a multi-center trial at 13 centers in Japan. They enrolled adult patients with frequently relapsing nephrotic syndrome or steroid-dependent nephrotic syndrome. These 66 participants were randomly assigned to receive Rituximab at weeks 1, 2, and 25, or placebo treatment. The primary outcome was the proportion of patients who were free of relapse of nephrotic syndrome at 49 weeks. The authors report a clinically significant difference favoring Rituximab with improved relapse-free rates, 87.4% for Rituximab compared with 38% for placebo.
There's also an interesting randomized clinical trial about dialysis strategies in acute kidney injury. In the Liberate-D randomized clinical trial, Dr. Liu and colleagues compared two dialysis strategies for patients with acute kidney injury who had been started on dialysis. Patients in the conservative dialysis group received dialysis only if the specific metabolic or clinical indications were met. Patients in the conventional dialysis group received scheduled dialysis 3 times a week until certain urine output or creatinine clearance criteria were met. The primary endpoint was kidney function recovery at hospital discharge. The investigators report that the, quote, as needed, unquote, strategy may result in a shorter time to and higher rates of recovery of kidney function. In the accompanying editorial, Dr. Wykar reviews the role of dialysis in patients with acute kidney injury. He emphasizes that although the trial is not definitive, it reminds clinicians to ask why when it comes to choosing dialysis strategies for patients with AKI.
Let's move on to chronic kidney disease, or CKD. The next two studies report results of meta-analyses from the SGLT2 inhibitor meta-analysis Cardiorenal Trialist Consortium. The studies explore sodium glucose cotransporter 2, or SGLT2 inhibitor recommendations for patients with CKD. In their meta-analysis, Dr. Staplin and colleagues included 8 randomized clinical trials that studied an SGLT2 inhibitor with a label indication for use in kidney disease and recorded longitudinal kidney outcomes and baseline data on albuminuria. They selected diabetes status and baseline urine albumin to creatinine ratio for stratification. The authors concluded that there were clear benefits of the SGLT2 inhibitors in this study population on kidney, hospitalization, and mortality outcomes, regardless of diabetes status or albuminuria status. And while SGLT2 inhibitors can reduce CKD progression, Dr. Nguyen and colleagues investigated how estimated glomerular filtration rate or degree of albuminuria may modify the effects of SGLT2 inhibitors on kidney outcomes. This meta-analysis included 10 randomized trials with over 70,000 patients to study CKD progression among patients with type 2 diabetes, CKD, or heart failure. They concluded that SGLT2 inhibitors lowered the risk of CKD progression regardless of patients' baseline estimated glomerular filtration rate or albuminuria.
Dr. Craig and colleagues comment on both of these meta-analyses in their editorial. They emphasize that the message is clear, quote, "These meta-analyses demonstrate that SGLT2 inhibitors are effective for reducing kidney disease progression, regardless of baseline eGFR, urine albumin to creatinine ratio, and diabetes status," unquote.
To round out these kidney studies, Dr. Estrella and colleagues examined creatinine and cystatin C-based estimated glomerular filtration rate, or eGFR. These are important measures for CKD diagnosis, staging, and treatment, but their values sometimes have discrepancies. This individual-level meta-analysis included over 800,000 individuals from 23 outpatient cohorts. The primary independent measure was defined as a large negative eGFR difference, defined as a cystatin C-based eGFR that was at least 30% lower than creatinine-based eGFR. Secondary outcomes included measurements like all-cause and cardiovascular mortality, heart failure, and kidney failure with replacement therapy. The authors found that in the outpatient setting, a cystatin C-based eGFR, at least 30% lower than a creatinine-based eGFR, was associated with higher rates of mortality, cardiovascular events, and kidney failure.
Dr. Saru Van Alpern wrote the accompanying editorial. It's helpful in providing more information about these measurements and summarizing up-to-date research that has highlighted discordances between creatinine and cystatin C-based eGFR measurements.
Readers may be interested in the JAMA Viewpoint by Dr. Pawar and colleagues, in which they explore different perspectives about patient participation in the kidney transplant selection process.
Next up, there's plenty to learn from the clinical reviews and education section. JAMA published a collection of materials summarizing the 2025 JAMA Summit on firearm violence. The special communication from the summit participants highlights 5 essential actions in the next 5 years to work towards safer communities. Corresponding author and pediatrician Dr. Frederick Rivara joins JAMA editor-in-chief Dr. Kirsten Bibbins-Domingo on the JAMA Clinical Reviews podcast. They talk more about the JAMA Summit's goal to create a safer world by 2040. And we highly recommend the accompanying video that highlights this important topic.
In the newest JAMA Insights, Dr. Morton explains combining medications like semaglutide and metabolic and bariatric surgery to treat obesity. And in one final nod to Kidney Week, Drs. Cunning and Alexander summarize the KDIGO 2024 Clinical Practice Guideline for the Evaluation and Management of Chronic Kidney Disease. It focuses on CKD classification and risk assessment and includes more on glomerular filtration rate estimating equations.
Let's turn to hemorrhoidal disease, which is a common condition affecting about 10 million people in the U.S. alone. This week's patient page reviews symptoms, diagnosis, and treatment of internal, external, and mixed hemorrhoids. And the JAMA Plus AI Conversations podcast features a great interview about AI and drug development. JAMA Plus AI editor-in-chief Dr. Roy Perlis talks with Dr. Kekus about biotech, AI, and the creation of new therapeutics.
And with that, there's also been a lot of rapidly developing medical news. Our outstanding JAMA Medical News team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at JAMAmedicalnews.com or click on the link in this episode's show notes. And be on the lookout for a special edition of the Editor's Summary this Sunday afternoon as Drs. Greg Kerfman, Bob Bono, and Phil Greenland discuss JAMA Network papers featured at the American Heart Association meeting.
Thanks, Preeti. And thank you for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Daniel Morrow, Ella Barnes, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.